I'd like to invite our plenary speakers to the table. Feel free to bring snacks. That's fine. So that would be Faith Gunning, Vikram Patel, and of course David Clark, who will be joining us soon.
Do we have seating assignments?
No seating assignments.
Very rule-abiding.
So as we wait for David, I'll tell you a little bit about myself. Benoit, you have not arranged an introduction for me, but I'll forgive you for that. But I am a clinical psychologist, a clinician scientist at Mount Sinai Hospital. I have the esteemed pleasure of being on stage with these three phenomenal speakers and researchers that I really respect, not only for their emphasis on increasing access to psychological treatments, which is a goal that I think all of us share in the room. The one thing that we really share is that we care about the well-being of the patients that we see. And I think hopefully we'll have a very stimulating and interesting conversation despite our different perspectives around this. One person, so you have been introduced to Faith Gunning, and you have been introduced to David Clark, but one individual who hasn't been formally introduced is Professor Vikram Patel. Vikram is not only one of my main mentors, but he has his biography goes beyond that. He is the Pershing Square Professor of Global Health and Wellcome Trust Principal Fellow at Harvard Medical School. His work spans the areas of mental health problems, child development, and adolescent health in the global health context, in particular the use of community resources for assessment, prevention, and recovery. He co-founded Sangath over 20 years ago, an Indian NGO which has won the MacArthur Foundation's International Prize for Creative and Effective Institutions and the WHO Public Health Champion of India Award. He co-founded the Movement of Global Mental Health and is a fellow of the UK Academy of Medical Sciences. He was named in the Time 100 Most Influential People of the Year in 2015. And if you haven't heard the news, as of last week, he was also named this year's Gardner Awardee. So thank you, Vikram, for joining us. And thank you, David and Faith, for also joining us and for your phenomenal talks this morning. I'm not going to talk that much because I know that this room probably has a lot of questions and conversations that they would like to have related to what they heard this morning, but also related to some of the work that you might know that Vikram has conducted really all over the world. But I'm going to start off with some questions. I would like this to be as interactive as possible, not only between us and the panel members, but also among the panel members. And so I hope that the panel members, David, I hope you're not running off now. I hope that the panel members will be interacting with one another because this is a unique opportunity for us to have a conversation in a small but somewhat large audience. So to kick off the conversation, I would like to ask all of you, what is the single biggest obstacle and opportunity in scaling up psychological treatments for common mental disorders such as depression and anxiety? And Faith, I'll ask you to start. There's a mic.
Oh, great.
There.
I picked the wrong seat. My most challenging task is getting the mic to work. Okay. From my perspective, which admittedly is probably more limited than the other panelists, one of the single most challenges is really moving, it's moving things from our clinical trials actually into the community.
Right.
And, there's often a disconnect between what happens in our research institutes and the community. So I am working in that direction, but I admittedly have less experience.
Okay. And the single biggest opportunity for scaling up psychological treatments?
So I'm biased, and I'm going to stick to my story. And I think that I think technology certainly offers us a tremendous advantage right now, and it's not going away. So we should be taking advantage of it for the service of our patients.
Great. Vikram?
So maybe, so this is a subject that I spend a lot of time thinking about, the barriers to scaling up things that we know work. It's something which is not only true for our field in mental health, but let's be honest, consider vaccines, something we've known has worked for 50 years and more than half the world's kids don't get them. So there is really a very important question. Why do things that we know work in science actually not get utilized? In fact, there's even, maybe pushback, as we can see in the vaccine case right now. And I guess, so the one thing which is not a barrier is science, because actually the science is already out there. The work that David described, all the papers he described is just one example of the science. The second barrier is the lack of political will. But again, you just saw this remarkable, and I wanted to say this, I didn't have a chance to ask the question or make a comment because there was such a queue. But I think David's talk reminded us that there is such actually, IAP for me is the best example of countering the nihilism that often exists in our field, that we can't do anything at scale. It's just remarkable. I mean, the story is just so remarkable. And I think, I always talk of IAPT as it's sad it's the only one, but it's still important that it is there. And I think there are many ingredients I'm sure David will speak to about what makes it happen. So the lack of political will is not a barrier anymore. In the case of mental health, let's be absolutely honest, there are governments around the world, including in very low resource settings, such as the ones I work in, which have already prioritized mental health. So that is not a barrier, because that used to be historically, we kept saying, oh, there's no political will, there's no political will. Actually, there is political will. So then what is the barrier? And I think there are many reasons, but one thing that is possible is that there is no commercial incentive. And I've often thought to myself, if I could take one of David's therapies and package it into a pill, it would be the single best-selling medicine in the world. But because we can't package it into a pill, and because there isn't a whole juggernaut of private interests to actually promote it, consider the incredible success of killing tens of thousands of Americans through opioids for what is really a moral despair due to their lives being transformed, and for which psychological therapy, you'd think, would have been the effective intervention. Instead, they got something which, of course, was being promoted by private interests. So I think, if I had to end my remarks here and stop my diatribe, is the lack of any commercial interest in psychological therapies. And I'd love to hear from others, but also from both of you. How do we make this interesting to the private sector?
Well, I agree with both of those sets of comments, which are really wonderful. So there are lots of barriers, aren't there? I mean, one of the ones I think is a political one, though. It is true that there's much more political will to do things about mental health. But until recently, I think most politicians have not really thought you can recover from mental health problems. They thought they need attention, and it's right to help people, and we should support them through their difficulties. But the idea that we have really good evidence-based treatments and many people can actually recover, I think is something that many politicians aren't aware of, and it is our fault. It's our fault because we don't collect outcome data and we don't publish it in our routine services. If you're in a cancer service, they do, of course, have a lot of data. The public does know what the survival rates are, even in local services. But as a profession, we haven't stepped up to the plate. We haven't gone for that public transparency. And so it has slowed down progress. I think with mental health, we're where cancer was 20 or 30 years ago. There was a lot of stigma about cancer there, and people didn't really talk about it. They talked about the big C, because they were ashamed about it. And why were they ashamed about it? Because they didn't think treatments worked. So what's the point of talking about it? But now, of course, we realize that many cancer treatments really can transform your life and can really change things for the better. But I think there isn't that wide public understanding yet of psychological treatments. I think the main impact of IAPT in England has been to make politicians realize now people can recover, and so that's why it's releasing an awful lot of money in the English system. But that's not generally true in populations. So I think the more we step up to the plate and demonstrate the value of what we do, the quicker we can change those sort of stigmas and biases. The other thing that I think is a problem is the way research is funded. So, you can write grants and get funding for a particular experimental study or a randomized controlled trial, but there's hardly anything in the grants which is seeing, and if it all works, can we get it into the health system? And that's a real problem when there's no other means. So obviously commercializing it is one way, and for some of the internet treatments and things, that you can go that way. But I think we really should also argue with our funding bodies to change the way they write the grants. So the virtual reality work I was showing you about, we've just recently got a government grant which is unique, as far as I'm aware, where it takes the virtual reality work we're doing with people with paranoid psychosis, and it starts by us having some members of the Royal College of Art who are very good at designing user interfaces and things. So they're improving the VR interface for the patients. And then it has a very large 12 different centers randomized controlled trial. And then if that works out, it has a team that are actually going out talking to all the health commissioners about what are the barriers to purchasing this. It has a spin-off company initially funded in the grant to make it widely available. And then it has an evaluation program of the VR in routine clinics around the country. And actually, that's the sort of grants we need much more of. But this is the first I've ever heard of it. And it was a unique government idea. And it was so unique that they didn't want to do it more than once. So it was a competition, a winner takes all. So there was 3 million quid, but only one person could get it, or one team could get it. And I suppose we just have to do our best to make it work so that that becomes more routine, because that's what you need, or we can't make this transition.
I had a comment, if that's okay. Oh, no, I have to figure that out. Oh, I succeeded twice. So it's interesting. I heard you mention this funding mechanism last night, and I think that one of the keys there is that the government has given resources for each stage of it. One of the trials that we're starting, it just got funded today, the goal really is to move it into the clinic if it works, and the demand is there within the funding mechanism. The money is not. So we haven't caught up yet. This is supposed to be a funding mechanism to move something from the clinical trial into care. But our government, there's some disconnect, because when you have people like me, who's a scientist overseeing a tremendous amount of work, it's not really my expertise. So I think you guys are doing something right. Your government is doing something right in many ways, both with the program you described and setting up this kind of funding mechanism that actually provides the support rather than relying on people to sort of find their way through.
I mean, I think this is an area where we can move things along, because when you talk to the politicians who set the budgets for these research councils and things, what they say is, we're giving extra money to NIH and others because we want to improve the outcomes of people in the population with these conditions. For most politicians, it hasn't occurred to them that the way they give the money isn't going to do much, because it's going to get some really good research, it's going to get some people very famous because they publish some great studies, but it's not going to have mass public benefit, because most of the politicians think if we put more money into the funding councils, we will get mass public benefit. And the issue is a strategic one for us. Do we explain to them that's wrong? The way it's structured at the moment, it doesn't work. But of course, your motivation is entirely right. So help us restructure it so we can solve the problem the way you think we're solving the problem, but we're not. Except, of course, Vikram in the third world.
Thank you to all of you for your responses. And we also know that there's new funding mechanisms, maybe not new, but recent funding mechanisms that are in place where organizations like PCORI, some of us may be familiar with them, with Patient-Centered Organization Research Institute, they actually don't fund the cost of the intervention. They want to fund what's already going on. And they fund these large-scale trials that allow individuals to fund interventions that they expect to already be happening in the existing healthcare, but don't fund things like cost effectiveness. And so there may be a trend, or there may be other initiatives that allow for different types of funding mechanisms. David, you had emphasized throughout your presentation, and also during the Q&A, the importance of measurement-based care. I wanted to ask, what is the best way that you think is the way to integrate measurement-based care into our existing healthcare system, say here in, you're familiar with the Ontario context, here in across Ontario?
I mean, I think, you know, the key thing is to work with all the clinicians so that they really want this because it's helpful for their clinical work. So that's where it all has to start, I think. And so it's really important to not implement it in a way which seems like an audit of your practice or some sort of unpleasant scrutiny. It needs to be something where people feel that using these measures really helps them improve their clinical work and makes it more exciting, because it reveals more therapeutic targets and what you can do about it. So I think that's where it has to start. But then, of course, you know, everyone needs appropriate support for it. And I think, you know, a lot of people, you know, will give questionnaires and things, but they just go in a filing cabinet, and it's extra work to get to, you know, plot the graphs and use it informatively. And that's no good with busy clinicians. So you need a modestly priced, because they often are very modestly priced, but bespoke IT system that supports clinicians doing this. And then I think you need to sort of create an environment in teams where people just are interested in the data and share it and discuss it. So in the IAP system, we bring together in a network of, say, a dozen different IAP services. We meet once every 3 months and we look at each other's data and we try and learn from it. We do extra exercise, you know, initiatives to follow it up to see what we can improve. So, for example, we found that, I don't know if it's true in Canada, but in England, it turns out that most mental health professionals are not good at picking up anxiety problems in the community. So if you look at a sort of the Adult Psychiatric Morbidity Survey, which looks at whether people have got a mental health problem in the community, and you ask a really interesting question, if it turns out you've got depression now, has any professional ever spotted that at any time in your life? For depression, it sounds good. 70% of people say, well, someone has said I was depressed. But if you take PTSD, it is 7%. If you take OCD, it's 9%. But if you say, okay, so no one has spotted your PTSD, no one has spotted your OCD, have they mentioned anything about mental health? And in 83% of those people, they say, yes, someone has said I'm depressed. So we've trained up our family doctors not to detect mental health problems, we've trained them to detect depression. And that's about it. And you know, so we thought, well, are we having a similar problem in IAPT? Are we under-detecting some of the things? So we used some automatic screening instruments quite independently of our clinical interviews, and we found that we were actually. And so we've revised our clinical interviews. So I think it's pulling different teams together to think of these sort of problems and then work together to solve them in a collaborative way, which just makes life so much more interesting as well. You know, it's worth getting up in the morning if you've got a problem to solve and you've got good colleagues who want to work on it with you.
Absolutely. Thank you. Vikram, I'm going to ask you to comment on the following question. So as a global health researcher and someone who's recently moved to the US, I wanted to ask your perspectives on what you feel are the key lessons that we should consider here in high-income countries from the many innovations that have been implemented in low and middle-income countries.
So you're asking me to give my talk, which I'm reluctant to do entirely, but I will say a couple of things maybe as a preview. But before I do that, I wanted to say something about the conversations we just had with David regarding outcomes-based measurement. I actually think this is one of the biggest barriers in actually convincing not just politicians, but also people who are in a position to invest in mental health care, is that we often have only input information. We trained 100 doctors, we saw 10,000 patients, but we have absolutely nothing comparable to what our colleagues in other areas of medicine have. For example, if, cardiologists would say, we save so many lives by having angioplasty. Whether that's true or not, we don't know, but they actually have numbers to, in fact, convince people who matter. So I think what you're describing is really not just important for IAPT. I think it's for the field of mental health more generally. To make a convincing case that we have effective interventions, we really have to demonstrate impact. And a question that perhaps you can answer afterwards is to go beyond clinical impact, because you made a strong point about the economic case. And I think that is extremely important to make the case why we should invest in mental health. But what would be really powerful would be to demonstrate, like people in the early child development field have so successfully, that if you in fact intervene, you actually see not just modeled economic returns, but actual economic returns at the level of individuals. For example, people returning to the workforce, people paying taxes. And I know you have information of that kind, but I'd love for the audience and for you to hear, to describe it. Now, to my question, I think the most important innovation is exactly the same as IAPT, but contextualized, which is to say, IAPT is operating in a country which has a universal health coverage system, which most countries in the world, in fact, do not have. In very many ways, Britain is a unique country in that sense. And having worked in the NHS, I can say that I have never encountered a healthcare system that is so equitable, so fair, so well thought through as much as the NHS is. It really stands on its own. So therefore, it doesn't necessarily always generalize everywhere else. That's the flip side. You don't have politicians who sit and listen to people like David and Richard. They don't do that in most parts of the world. And that is not to say that there aren't people like David and Richard in other parts of the world. There are real structural differences in the way Britain organizes its social welfare state as compared to most other places. So context is different, and in the context I work in, the equivalent of IAPT would be essentially to use community health workers. And I'll talk a lot more about that. The idea is exactly the same, actually. Philosophically, it's a very similar idea. The differences lie in really the kinds of providers that you have available to you. In Britain, for example, there is a lot of people who have done masters and PhDs. In most parts of the world, they don't exist at all. It's a completely vacant space. I'll also talk a little bit more about guilds. Guilds are another very important factor, which, in a way, the advantage of working in a place where there are no guilds is that you can do very, very disruptive things in a way that has no pushback. And I think that conversation we had earlier about psychiatrists, psychologists in the US, I don't know, someone raised that question. It's a classic example of a conversation you never hear in Rwanda, because neither of them exist. And therefore, you can actually have very disruptive innovations without that pushback. Now, what is the implication for high-income countries? I think guilds have to be reformed. I think there has to be an engagement of guilds with thinking about public health, about scaling up. And again, I'll be interested to hear from both my fellow panelists how you might see yourselves doing that. You referred to this a little bit in your conversation about the parallel system, and I wondered to what extent that was a guild issue or some other kind of structural issue. But the fact that it was separate from the main NHS, or at least I heard you say that, and I may have misunderstood. I'd love to hear why that was. But certainly I think the power of the guilds in influencing how money is spent and devolved is something that I think should be rethought in the West.
Thank you. David, would you like to respond to either of the comments that Vikram mentioned?
I mean, I think Vikram's absolutely right. Guilds are a big issue, more so in some countries than others. In the English system, I was painfully aware of that, and so that's why we actually didn't consult with the professions when we got going on this. So Richard Layard and I just went direct to the Prime Minister and didn't discuss this with any professionals other than the Prime Minister initially. So we just had a big idea and we tried to sell it, and they listened. And then I think, of course, you're in a different position because then you've got government support for a big program, and so it's easy to bring everyone along with you. But my perception was if we had tried to bring all of the professional groups along with a vision, we would still be discussing what the vision is 10 years later. So I think there has to be an element of, as you call it, disruptiveness to deal with this. But at the same time, you can't exist, you know, in a vacuum. So you do need to bring people along. But my experience has been, you know, do not ask what is it, go and make your visit, is what T.S. Eliot said about it. You just get on with it and show that it works in a small way, and then bring other people in, I think. And now we have a lot of support from the different professional groups in England for it. But certainly on outcome monitoring, my name was mud, I think, in my own profession in clinical psychology at the start. But now, you know, people think it's great and are following it through. One reason why they think it's great is a good reason. We've tripled the amount of investment in psychological therapies as a consequence of IAPT. We haven't taken investment from other psychological therapy things, but we've added a lot on top of it. And that has been because of the point you make of the outcome data, because that's what's released the money. Yeah, so the question was, do we have any economic outcome data? So the argument was based on existing research, really, that sold it. And because we have an IT system which is separate, because that was a way of getting it cheap, we don't connect up to all these other things. So it's only recently that we've been getting the data on these other things. And at the moment where we're getting the database is other healthcare utilization. So we're now linking the IAPT data set up to the secondary usage data set, which is sort of outpatient appointments, inpatient appointments and things. And that was the thing I was mentioning where I was showing that we're saving a lot of money in physical healthcare costs. And recently, the Department of Work and Pensions has also rather belatedly got interested in this and the idea that we're changing, you know, employment and things. So they're now allowing some linkage of data on employment as well, so we're getting that. But you build it slowly. I mean, I think one of the things you need to avoid doing is getting into a situation where you say, well, you know, we've got good reason to suppose this would work and it would save this money, and you know, we will demonstrate that in year, because that's sort of almost impossible, I think. So you have to run the argument based on existing research and then be allowed some time to get the system up and running, if that makes sense.
So I wanted to go back to this issue about outcome data that you both brought up, and why we're not doing this, or what the resistance could possibly be. It's common sense that when you do an intervention, you want some data to show that it works or doesn't work. So is there something specific about mental health that you think that why we're so far behind? Or is it that people think there's more art to it, or we don't need to demonstrate it? It's for our own good. As a psychologist, I can't imagine wanting to do anything and not having data to show what happened at the end.
Well, I think it's important for us not to beat ourselves up too much. I think it's important to realize that in lots of areas of physical health, they don't have outcome data either. So if you look at hip replacements, you don't get outcome data. You know how many hip replacements were done. We don't know whether someone's quality of life has improved as a function of that. So, you know, in many areas of physical health, we actually only have input variables. We just have the number of operations, the number of people who have seen this, and how long they wait. So, you know, we're in a sense aiming to do something which goes beyond the standards that many areas of physical health have got. I mean, if the outcome is whether you're dead or not, well, that gets counted easily. But for other things, you know, have we improved people's life with physical interventions? There's rarely any evidence for that. But we're saying, you know, in mental health, we want to be able to show that. So I think it's important to recognize that and say we are planning to do something very ambitious by doing this. But at the same time, you know, it is the best way of serving our population, isn't it? I mean, people with mental health problems have their lives destroyed by it, and I think they need to know that what we're doing is something that can help many people, because otherwise they won't come forward for treatment. And there's so many people who, even if a treatment is available, won't come forward for it because they don't understand that.
Are you aware of any, so you have a great system set up, but within the US, are you aware of any analogous system, of a large system of collecting mental health outcome data?
Well, I think, as I understand it, the sort of Los Angeles initiative that Lynn McFarr is just starting, he's going to have exactly the same outcome monitoring system in it.
There's also the UW. UW has a very large.
Yes.
So UW in Seattle has been running a very large program for quite a while, actually. And Jürgen Unitzer now leads. Yeah. So, I mean, but it's interesting because UW also operates in the Pacific Northwest, where there's a much more similar system as you have in Britain, because there's more of a single-payer system, etc. The more fragmented healthcare becomes in terms of provision and paying, the more difficult I think it becomes to have these sorts of investment cases made. But I had another question for both of you about outcomes monitoring. One of the reasons I've often heard about the difficulty in our field is that you're right, mortality is a big driver in global health. Yeah. And maybe less so now in the West, but certainly when it comes to global health and questions about development assistance, etc., it's all about mortality. And mortality is easier to count because it's done routinely. And so one of the challenges that's often mentioned is it is very complicated to get individual level mental health outcomes because our methods rely on really quite old-fashioned ways of asking people a bunch of questions, and there are further questions about the validity of those, et cetera, et cetera. So my question to both of you was, given this new field of digital, biomarkers, as some people I think call it, using passive and also maybe active remote monitoring of people through apps that people can download on their phones. Do you see that as a potential in the future, or do you see there's any science around that?
I think the part of that monitoring that is the most appealing to me right now, the active people answering questions. I'm not sure how reliable that is. I think the part that's the most compelling right now is some of the passive data collection specifically, but they're more basic functions like related to motor speed and predicting and how that may tie to relapse and things like that. I don't think, and some of the cognitive measures, we certainly have some groups who are doing really great work in that area. I'm a little more skeptical about some of the, people being asked 4 times a day how they feel. But I'm biased and I'm open to somebody telling me why I'm wrong.
Well, I mean, this is obviously a very interesting area, and there's quite a lot of work going on. Tom Insall, now that he's not running, the funny thing, through Mindstrong is doing, of course, a lot of work in that, and it's very interesting. Obi Felton in Google X is doing something similar as well. And this is largely, passive stuff from mobile devices and things, isn't it? And certainly, Tom has shown me some data where he is picking up a sort of early sign of a relapse and things quickly from doing this. So I think, in a sense, this will augment our outcome measures. But I think, our biggest problem is not agreeing on what's a good measure, but agreeing that no measure is great. And those are both fine things, but what is not fine is therefore saying we're not going to do anything. And that's, I think, where we fall into the trap often. So I think one of the key arguments for IAPT was creating what we called a minimum data set. So, we had a large group of people, an expert reference group, discussing, well, what should be the ideal measures that we should use. And we came up with about 100 measures that we should use. There are good cases made for every single one of them. But we decided in the end, the way through that is to say, well, we're not trying to measure everything perfectly, but we need to measure something. So we'll agree on an absolute minimum set of things that we'll measure. And of course, individual clinicians can measure many more things. Therapists in my team measure many more things than are in the minimum data set. But we will agree on this, subset of things. And it has turned out to be a wonderful thing to do because we just learned so many things we never dreamt were true with that. So I think it's very important not to, get into a situation where, fear of not being perfect prevents you from doing anything. I mean, that's a condition that we would treat in our patients, but not always in ourselves.
Thank you, David, and to the rest of the panel speakers. So I'm going to invite people to come to the mic. The mic on my left-hand side of the room if you have questions. And as you're lining up, I'm also going to ask I myself am going to ask one more question of Faith, which is, do you think MRI or other neuroscience techniques can improve the ability of clinicians to personalize psychotherapy interventions?
I think there's promise, and if the audience couldn't have guessed that I would have answered that way, then I didn't do a good job in my talk this morning. I do think that I think it's a very exciting time in the field. I think that we are very close to making what may be some major breakthroughs in our ability to use MRI to actually assign people to treatment, and we have some very compelling data. A lot of groups are working on this, like any other area. Once it's very sexy, so to speak, you have to sort of wade through the good quality and some that may be more opportunistic. But I think it's an advancement of our analytic techniques that, if done wisely, I do think we're going to be able to use measures of brain function to assign people to treatment. And I know it sounds, you talk about areas that are not wealthy or very under-resourced, so it sounds sort of out of touch with reality in a way, but I think for conditions that are very expensive, things like treatment-resistant depression, undiagnosed psychosis, I do think we're going to be able to use MRI to get our patients better treatment faster.
Okay.
Raj.
I think it's important to let people know who you are, simply because it's relevant, I think, to some of the discussions we're going to talk on this panel. So Daisy is our assistant professor from the Mount Sinai Health System, clinician scientist, right? Investigator for children's mental health, maternal health, and recently has been maybe the youngest recipient of a huge grant, a $13 million grant, I think, multi-centered trial. One of the sites is in Toronto, and it's about scaling up psychological treatments for perinatal depression and anxiety via telemedicine. Maybe you can talk a little bit about that and how it impacts the discussion here of the future of psychotherapy.
Whoa, talk about putting me on the spot, Raj. That came out of the blue. Right, so I am the youngest recipient of a grant that was funded by an organization called PCORI. I have been working at Sinai for the last 2 years. Sometimes it feels like 2 months. Forgive me, Molin. For the last 2 years, and my colleagues, Paula Ravitz, Molin, Benoit, David Clark, Vikram, all have played an integral role in developing this grant. What we plan to do is, I'm a global health researcher at heart. I've had the fortune of being mentored by individuals like Vikram, Francis Aboud, Claire Payne over the last decade. I know some of you might look at me and think I'm in my 20s, and I'll take that as a compliment for now. But nonetheless, I've seen a lot of things that have been implemented in global mental health settings with great innovation and speed and efficiency. And I came to Toronto mostly for personal reasons. And I came to Toronto wondering if some of these innovations could be implemented here in Toronto, but also in several sites in North America. My main focus is perinatal mental health, perinatal depression and anxiety. And so what we plan to do in this large randomized control trial, it's a non-inferiority trial, and we want to see if nurses can deliver a brief behavioral activation treatment of 6 to 8 sessions for perinatal mental health. Are they as effective as our specialists, psychiatrists, and psychologists? We also want to see if this intervention is delivered in person, is it as effective as the same intervention being delivered via telemedicine? And so we have several sites across Toronto, including Sinai, including Women's College Hospital and St. Mike's And we also plan to recruit from North Carolina, Chapel Hill, where my co-PI, Samantha Meltzer-Brody, will be, and the University of Chicago. So I think that this is a great opportunity to examine some of the questions that we've raised today, but also for me to gain some of the gray hairs that David was mentioning earlier in his talk over the next 5 years as I take this on. And so I open up the floor. Raj, I hope you don't do that again, because that was terribly embarrassing. And I'm more than happy to talk about the grant and the details in more detail after the panel. And I invite the next questioner to ask the next question.
So David, you've very adequately demonstrated how you can take research from lab all the way to the population in psychological interventions. Interestingly, a little bit of reflection, insulin was discovered here in Toronto. I think mid-1920s. It was available within 2 years. Of course, the outcome of diabetes didn't improve till they put in stepped care and chronic disease interventions. Well, interestingly, if you take something like PTSD or depression, we have known about the effective interventions for the past 20, 30 years. But still, the translation is lagging, except in places like UK. So is it time that we should be thinking about focusing more on translation? It's important to find out new things and exciting things about processes, etc., and that should go on. But in other places which are not like UK, should there be funding more allocated to translating it to population, perhaps the kind of research that you're doing, and that could change how we perceive inequity and equity as well?
Well, I think it's both, isn't it? You can get a lot, I think, from more systematically implementing things that we already have. But you can only do that if you have a data set on everyone. That's the key thing. Once you start getting these data sets, then you can look at the benefits of more systematically implementing things that some people are doing and maybe others aren't, as well as getting things into practice more quickly. But I think we are getting a lot better at getting things into practice more quickly. When I do a sort of undergraduate lecture in Oxford on this, I give the story of vitamin C. You know, we used to have these ships that would go from England to India. It takes a rather long time, or a sailing ship. And there was a trial done in 1624 where they sent three ships, and one of the ships had barrels of lemon juice on it, and the sailors got the lemon juice and the others didn't. And the two ships that didn't have the lemon juice, 80% of the sailors were dead by the time the ship got to India. But the one that it did have it on, I think it was, I can't remember the exact numbers, but it was only about 30% were dead. Still quite a lot, you know, but a very big difference. It took the British Navy 264 years to implement that practice. So, you know, we are getting better. It's speeding up.
Thank you, David.
Sorry, this is two questions for the price of one. You can decline to answer one or the other.
And sorry, can you please introduce yourself?
Oh, sorry, Jan Malott. I'm a psychiatrist here at U of T. So the question about groups and group therapy and scaling up, I mean, those are things that we're not great in training psychiatrists in Ontario, but just wondering about the role of groups and scaling up, both in UK and across the world in terms of access. Question one. Question two, what about the role of common factors in kind of scaling up? My understanding of the psychotherapy literature is that variance in outcome, modality specific, and adherence to modality is important, but there's a lot of other unexplained factors, and some of the explained factors are common factors like therapeutic alliance and such features. So is that part of the kind of implementation and scaling up and ensuring, you know, greater success of modalities, that the common factors kind of being delivered in conjunction with the modality, such as therapeutic alliance? So those are my two questions. Thanks.
So on the common factors, it's definitely not either or. You can't really train someone well unless you train them in those common factors, and in addition to that, you train them in the specific things. If you just train them in the specific things, then you don't really get very far. But how the common factors play out is actually quite interesting in some of these innovations. So if you look at the issue of therapeutic alliance, say, and you look at these internet treatments, you know, one thing that people worry about is say, well, you know, if you're only having a phone call once a week with your therapist, or you're mainly communicating with messaging in the secure program, can you get, you know, a similar therapeutic alliance? Actually, it turns out that you can, but if you work things a particular way. So in our trial comparing face-to-face social anxiety treatment with internet treatment, the therapists, it's the same therapist delivering both, so they, you know, get the experience. And if you get their ratings of therapeutic alliance, they think they have a better therapeutic alliance with their patient if they do face-to-face therapy than internet therapy. But if you get the patient's ratings, they say there's no difference. They think it's very good both ways. And it turns out the patients are right, because the only thing that predicts outcome is the patient-rated therapeutic alliance in this case. And so then you can ask, and we did do this, we did exit interviews with all the patients to say, you know, so what was, you know, how did you find the relationship with your therapist, the ones who are going through the internet treatment? And, you know, you could have had coming once a week to meet that therapist in person. You know, what would that experience have been like, and how would it be different? And people's answers were really interesting. They said, well, you know, it would have been interesting to meet the therapist in person once a week, and I think I would have enjoyed that because, you know, I've got to know them on the internet, and I think they're a really nice person, they're very supportive and things. But they'd have only been there for an hour once a week, whereas on the internet program, they're there all the time. Because, you know, I do something on the program, and I know they're going to look at it the next morning, because that's how it's organized. You have a sort of screen, you see all of your patients. Every day you look at what they've done, and you send them brief messages. And the patient said, it's sort of like the therapist is always there. It's a bit like, you know, when I'm having a text conversation with an old friend. They may be in another city, but it's almost like a continuous conversation we're having, and I feel they're there. So, you know, these common factors are very important, but the way they play out with new technology is different, but can be marvelous.
Any other thoughts on scaling up group treatments in any type of context, Vikram or Faith?
So maybe also on the common factors, I completely agree. In fact, I had a question for you, David. What does the counseling intervention in NICE mean? I'd like you to maybe just speak to that, because the others were very obvious, but I didn't know, because counseling is one of those black boxes which can often be interpreted in many different ways, and I would imagine a lot of that is actually common factors. In terms of groups, you know, I will talk a little bit about perhaps one of the most historic, in the history of the innovations that have happened in the Global South, perhaps the first and really most remarkable example was the use of groups in rural Uganda. And I will speak to that. And we tried to actually replicate that in India, and we found it quite difficult. So I don't, they certainly work, and I think there's a lot to do with context. And the context that we noticed the difference was that in Uganda, these groups, which were IPT groups, in fact, were being done in villages, where it was not uncommon to meet as a group to do actually problem solving that, you know, affected all kinds of things, you know, wild animals or you know, agricultural issues and so on. So it was a very easy sort of format for people to understand. But when we tried to relocate that in primary healthcare facilities in India, there were all kinds of different barriers, because primary healthcare is a building that serves a large catchment area, and if there's a bus that operates only twice a day to take you to the clinic and back, people can't wait and form a group, because if they miss their bus, well, then they're stuck there for maybe the rest of the day. And so there's a rush to get, you see, it's almost a structural logistic barrier. I'm pretty sure if we had the tube, for example, then maybe people would hang around in the clinic for the group. But that is, of course, only present in London. So we'll all have to go there.
Thank you.
Can I answer that question about
Yes.
counselling? So, of course, Vikram's right. This counselling is a generic term, and it covers many different things. So we got NICE to look at that, and we got them to look at what was the counselling that was delivered in the randomised controlled trials that, you know, gave some support. And it seemed to be, there was a relatively distinctive form of humanistic counselling that seemed to have been most commonly used. So we got together with the British Association of Counselling Psychotherapists, and wrote a specific curriculum for IAPS on counselling for depression, which was that form of counselling and a lot of extra training in how to deal with someone who is specifically seriously depressed. Because we found that quite a lot of our counsellors hadn't really had the specific training in depression, and so we needed to add that to it. So it's not just generic counselling, and I think that's probably quite important. On the groups thing, the other thing, I mean, obviously it's very tempting to think, well, you know, you can see many more people in a group, so that's a good idea, and it often is. But I think you wouldn't want to see that as the main solution to scaling things up, because there are also lots of people who groups don't work well with. And, you know, for me, what's been very educational is our work with social anxiety, because when we started, the gold standard treatment was group CBT. And people thought that was definitely the way you should do it, because you could do all these role plays with the other patients and get a lot of exposure very efficiently. But we weren't really well trained in groups, so we just pushed ahead with our new treatment individually and got very good results. But then we had colleagues who were very well trained in groups, and they said, well, it'll do even better if you do it in groups. And so there's a German group that compared the individual treatment with group treatment. Their belief was that the group would do a lot better. There's an Irish group who did the same. Both of them found their beliefs were wrong, and both of them got poorer outcomes with the group, which is why NICE now recommends not doing groups of social anxiety. But I think the reason for it is that the devil is in the detail. And if you're taking a cognitive therapy approach, it's all to do with the real detail of these particular thoughts and what it is that's convincing to that person. And it's just so much easier to get into that in the individual work. But the other problem is with social anxiety that the more severe people will not turn up to a group. It's just too intimidating. But they're the people whose life we can change more than anyone else.
Thank you.
Where we've seen, I think within the US systems that I've worked within, where we've seen the most success with our groups are they're really skill-based groups to augment, maybe not the primary intervention, but a lot of times with children who are being treated, we'll have a skill-based parenting program, or some of the, you know, the social skills groups. But what we have found for conditions like autism spectrum disorders is the direction may more be to have individuals who are also modeling the social skills that the other kids should be emulating, not just all kids who have social skill deficits. So I think the groups are very helpful for certain conditions.
Right. Interesting. I know you've been standing for some time.
I'm Sarah. I'm an occupational therapy student. I'm just wondering what you think that frontline clinicians who don't really have economic or political ties can do to help facilitate these kind of grander futures that we've been talking about.
Well, I don't think you need to have economic or political ties. You're a voter. You matter. In every democracy, you matter. And there are lots of ways in which, you know, you can push the argument for improved mental health services, I think. I mean, I think a lot of us as professionals feel a little bit powerless in the sort of political domain, but we're not. We have the ultimate power. We have the vote. And there's so many things you can do with petitions, just talking locally to people to try and release expenditure and things. I mean, that's the thing I've learned more than anything else. I've never seen myself as a political animal, really, but I've discovered that we all have extraordinary power. Of course, in England, we're discovering that sometimes that power doesn't work out, as you may have noticed with Brexit. In fact, we had an extraordinary petition which attracted 6 million signatures in just 1 week, and the government managed to say it's irrelevant because there's not enough signatures. So sometimes it doesn't work out.
I think also, as a clinician, if you were first, you want to use best practices yourself. And if you were training other individuals, then I think the reach can actually be quite powerful. And more than, over time, more than what you think it can be.
So I have one final question if there aren't any more. Vikram, you had discussed guilds and how they can sometimes be a barrier to access to treatment, and both Faith and David, you had talked about that as well. I'm wondering, what do you think is there an opportunity here to resolve that, particularly in high-income countries, possibly like Canada or the UK, to overcome that barrier of guilds?
Well, I think there is enormous opportunities to do that, isn't there? But I think it's really important to remember that guilds is made out of people. So, you know, the thing to do is to make allegiances across guilds with individuals, and then you can get something going and things start to dilute and the barriers start to come down. And that's been our experience with IAPT. You know, it is a multi-professional thing, but it's reaching out to people of interest in lots of different guilds and getting them together as a coalition. And these things start to change.
Thank you.
Yeah, I think that's exactly my strategy as well. You know, I've been very active with the World Psychiatric Association, for example, and one of the main reasons I do that is because I do think that change has to happen collaboratively. It has to happen. I think the moment you sort of create binaries, you know, you don't believe in science and we do, I think you've probably lost the opportunity to actually engage practitioners. So I think certainly that is a very important piece, but there is I think still a very important structural barrier which I haven't been fully able to get around, which is how do you incentivize people to give psychological therapies? I know that in the US, for example, you know, a lot of that is determined by the insurance industry. You know, so if there isn't actually an incentive of some kind, and let's be honest, I mean, you know, the most important kind is monetary, as a practitioner, that is. How do you create that value for such an effective intervention? And I've struggled with that. You know, when you work in universal health coverage system where the government automatically pays you, you don't have to worry about that. But in so many other healthcare systems, and this goes back to my earlier remark that Britain is very unique in that sense, and a few other countries too, not just Britain, but most of the world's countries don't operate like this, and it's a very complex mixed payer system for healthcare. How do you create value for something that is often intangible? It doesn't have a clear boundary to it. It's not a pill and not a bottle. How do you do that? And I haven't figured out exactly what the solution there might be.
Faith?
So I'm not going to answer that question. But I guess when I was thinking about guilds and more of a collaborative approach to things, I as a psychologist or somebody focused on human behavior, I do think a lot of it's about modeling behavior, and it's about modeling behavior to people that we're mentoring and training, as far as, you know, I have never, from my own personal experience, is that I work with people from multiple disciplines, and I don't really see the distinctions very clearly, and I'm not treated as a higher or lower class citizen, and I probably gravitate toward those groups. But that is also the kind of behavior that I would want to display to the people I'm mentoring and training.
Great, thank you.